No way that's a coincidence. I knew you did. All right. So here's your scenario. This will be fun for a second. And it's going to bring up past anatomy into what I figured out. So last Thursday, I was going to build a scenario for you, but we'll get to that. Last Thursday, let's just get it. Patient presents to the emergency room, right? And comes in and tells them, listen, I was sick. I felt kind of sick Thursday to Saturday. And you ever had that feeling, like that buzzy feeling? Like you feel like you're getting a cold, you know, it's kind of anxious, and you're just tired? I had that. And so I didn't have like full cold symptoms or anything. I just didn't feel good, but I went down to the beach, I mowed the yard out in the heat and stuff. Then I got back here Sunday, and I decided, you know what, I'm going to do something I never do. I'm just going to do nothing all day long. Just didn't feel like doing anything. I watched a 6-hour, 2-episode of Billy Joel documentary. That is one of the best documentaries I've ever seen if you like Billy Joel. If you don't like Billy Joel, it's probably because you never listened to him. But if you want to hear the full explanation between his life and every song he wrote, great writer. Anyway, but I'm like 6 hours in, people come home, and like I didn't touch my phone probably all day. I'm laying there, and I got up and I felt my neck tighten up. But then that just got worse. Sorry. So I'm just miserable, and I'm hurting like all down my, like pinpoint into my shoulder. I mean, it was just killing me in my shoulder. I'm leading y'all into symptoms here. Oh, it's just killing me there. And then sometimes they call this a trapezius ridge. And then it started spreading, and it went all the way down to about where I imagine my diaphragm. Esophageal hiatus specifically, because when I drink some water or something, it just kept getting worse. And, sometimes you drink water, I drink water fast, so I think. And it kind of, you don't really hiccup or burp, but you can feel it right there at that. When it would do that, it would just shoot pain. So I lay there all day long. So I came home Saturday. Was feeling bad Saturday. This all happened Saturday. So Sunday I get up and decide I'm just going to hang out. But I'm only comfortable, and I'm just hurt. And I can't decide. So I spend Sunday practically just, I got to be up and walking around. Because sitting down is miserable, laying down is miserable. I start to think, my goodness, man, am I having a heart attack or something? Now you get that feeling. And I'm like, no, I'm too tough for that. But it's very hard to diagnose yourself. You think you'll be good at it. When you're sick, you're the last person that needs to be diagnosing yourself. Because you're really not thinking straight. And I took a muscle relaxer. And, I'm like, so I'm stumbling up, but I'm refused. My wife's going, you're going to go to the ER. No, I'm not having a heart attack. I knew when I went there I wasn't. But I'll shorten this down. But my symptoms were all the same, that same area. But when you got kind of, I didn't know if they had chest pain. It was like straight up the side of it. But it just kept getting worse and worse. And I'm like, all right. So am I having this right? I start thinking medically. I'm like, what's our differential here? Somebody comes in with that. Could they be having a heart attack? Yeah. 54? Yeah. Before we get to the vital stuff. And you say, well, what else could it be? This right where it's on medical, I start going, what? Could you be having an aortic aneurysm? Could you be having a dissecting aorta? Splitting the wall slowly, which sucks because by the time you get there, you're dead anyway, probably. That's. I mean, I better just stay home. You go to the ER. You think you have a dissecting aorta? Hang out with the kids. That's your last few minutes. Don't worry about what if I stand up, what if I fall. It doesn't matter whether you're standing or not at that point. And then I started thinking, well, is it pancreas? No, it's not radiating to the back. And I'm like, is it? Then I got to, this is what finally got me. I'm like, I think maybe I did have a viral illness and I maybe have pleuritis. Because when I take a deep breath, also I can feel it in that spot. Like when my diaphragm hits a certain point, I can feel it. I thought maybe pericarditis or pleuritis. That's where I'm at. But it got so bad that I actually got the feeling of if I don't go, this is about to get much worse. So we drove over to the Barney ER, and you already know I don't like the Barney ER. I don't go to the hospital at all unless I have to. People go there to die. Anyway, I tell them all this, but they've already hooked me up to it. They weren't very quick about it. I saw A&P up front and 2 nurses, and they drew blood and put me on the monitor. Blood pressure's rock solid. I'm bragging. 117 over like 70. Yeah.
That's right.
That's going to be in this story too. They have already, they're doing pulse checks on each arm and strength tests. The nurse did real quick, like 10 seconds. And I already know, what's he doing? He's like coarction of the aorta, different things. You got different pulse pressures, different arms, that's a bad deal. It's the only time they touch me. Tell you more about that later. So the nurse practitioner comes in. I'm not putting down any individual nurse practitioner, but this one I am. But I'm talking to her, and I tell her all this. My wife's like, you just telling her the diatribe story. I'm like, that's called the scenario, because you want to know what led to this. And she talks to me for a while and decides, well, I'm not worried you're having a heart attack. I said, I'm not either, but I want an EKG to make sure. You may not leave it. That's why I really went thinking, I'll just get an EKG. Because here's the truth. I ain't told her this. Listen, if it's pericarditis, there's nothing really you can do for me. Because I can't take a bunch of NSAIDs every day, and that's really treatment. You can take colchicine. I ain't taking colchicine. I don't like what it does to people. Steroids, but I'll shoot you. I'll give you a steroid. I mean, truthfully. And poritis, I don't really think I have poritis, but she said, what do you want to do? She's going to, you want to get CT of your neck and chest? And I'm like, no, I can't take the contrast. Anyway, it wouldn't be bad. So I'm talking her through this. And I said, well, just take a chest x-ray. Let's get a portable chest x-ray and EKG and send me out again. And I'm fine, give me some muscle relaxers or something, I'll be good. And that's what we wound up doing was, they came in and she ordered like right after she came in, I was pretty uncomfortable, so she ordered something I've never taken, and that was Valium. I'll never take that again. I'm not a good druggie, much as I joke about my prior life, but no. That thing zonked me. I don't know who would take that like want to feel good. I was still feeling that thing when I was in here yesterday morning. I was out of it. Y'all surprised me. You make a good game. I don't feel great today either, but you make a good game. They gave me the Valium. And then she said, okay, well, how about steroids? She said, I'll give you an IV dextromethasone. All right. Never had that either. I've had a lot of steroids, but not IV. That was a unique experience. Anybody ever had that?
Did it push you slow?
No. Didn't even say anything. He just, and then walked off, and he got about 5 seconds away from me, and I went, whoa. And all I can describe it as is it felt like I had a sparkler up my hand. I thought, dude just killed me. That's the best description. I even told him that. I said, but if you ever wonder how fast a drug, an IV drug, reaches you, about 5 seconds, it hit every part of my body with numbness or like tingling on fire. I was like, I don't think that's right. Went away quick. Okay, I got to finish this up. We just started, but so then they let me out of there. And I go home, and I'm still not satisfied because the only reason I went there is just because you don't want to be stupid and make sure you're not dying. But you also don't want to be that person who shows up at the ER going, heart attacks. They come in all the time, so they blow them off a lot. But I was driving home in the car, I looked on the volume, and I looked at my wife, and I wasn't driving. I looked at my wife and said, they never, remember what I told you? Out of that whole time, I was there 3 hours. The only time they touched me were my pulses on my arms to put an IV in. They never put a stethoscope on my lungs, never listened to my heart. I'm like, no physical exam. Are you kidding me? But I was kind of out of it by then. Plus, I could touch it. I'm not a good patient.
I'm not.
Yo, I'm going to braid every class from here to the end. We are PAs. We will put a fucking start. We will put the stethoscope on somebody. And I get it that I go hard and say, I don't care if it's a torn meniscus. Put a stethoscope on them. You may catch something anyway. But if they're having chest pain, What kind of damn stethoscope on? I don't get that at all. It's been irritating me ever since. But anyway, I was laying in bed that night and I thought, this is why I told the whole story. We're coming back. Okay, picture that I have been running. Newly running, haven't ran since like 2016 unless somebody was chasing me. So you're getting back into running. Okay? That's one thing. You're having pain all up kind of up your cervical spine, that you can feel there, and tightness, and it's out in your shoulder, and all the way down. Why would it be down at your, like down by where your diaphragm feels? Why do I still feel that now? So I'm thinking through all this. And then I start thinking about what we learn in class that we don't think is important a lot of times when I'm asking you questions like, what runs very close, do you think, to your scalings? Remember, I was sitting for 6 hours, and I was lounged back, and I read my phone for about 15 minutes. People pulled up. I set the phone down, and as I got up, I felt both of my scalings. I didn't know, not thinking scaling at the time. My neck tightened up on both sides, mainly on the left. There are transient nerves in the neck. Do we still remember those? What's the most important transient nerves that go through that area? Phrenic. Phrenic comes off C3, C4, C5, right? It runs, we didn't get this specific, but it actually runs between, a lot of times, the anterior and middle scalings. And if that tightens up, what could you have? A nerve entrapment. So I think I have a nerve entrapment of the phrenic nerve on that side, and that's why the diaphragm seems irritated. And sounds a lot less concerning. They didn't go down any of that route. Crazy people. Crazy people. Oh, I don't know if I forgot anything. I was going to write a scenario, but I got lazy. I wasn't going to tell y'all it was me and walk you through it, but what they say. Eat right, exercise daily, still diet. Oh, why did I bring in the running? Anybody figure out why I wanted to make a note that, hey, I just started running again 2 weeks ago? Do you think I'm in great shape for running right now? Do you think that I used to run a lot? What do people who used to run a lot do? They push it harder than they should in the beginning, right? Because they just remember how they used to run. What do you use when you run? Diaphragm, but what helps your thoracic cage expand? Sternocleidomastoids and your scalenes. You ever see somebody in an asthma attack? You'll see those scalenes pop up in their neck. Same thing happens when you start running and you don't have your breathing down. Maybe you push it a little harder. You'll start trying to get those extra breaths in, whether you realize it or not, you're tightening your scalenes up. So all of that leads me to, I think I'm right in my diagnosis. So, unfortunate for y'all, I will be here for the rest of block 7. It's block 7, y'all. And we're done. Get a break. All right, sorry. I always tell y'all too much about me, but that was my weekend. I did get the yard phone. So. We're going to go into the lower extremity. And y'all did very well. I know you never think so. Y'all did, what was it, 92 average and no failures. Really can't get much better than that around this place. That's a good average. And when we don't have any failures, that's awesome. Right? Even when we do, we're still going to be fine. If you liked upper, whether you liked it or not, I'll tell you lower is set up the exact same way, studied for it the exact same way, and I think the lower extremity is easier than the upper. One, we don't see as many forearm muscles that we got to figure out actions for. We don't study, we're not going to go into like tarsal tunnel syndrome because we don't see that a lot. And so to me it's easier, especially when you get into the leg compartments. They're not like the forearm compartments as bad. You can agree or disagree as we go through this, but study the same way you did for that one. And so we got to go through the gluteal. We're going through our regions again where, let's just go to the picture where we have our gluteal region, our butt. We have your thigh, everything from your hip down to your knee is your thigh now, your leg. So when we say leg, we don't mean the whole leg. We want to say the whole leg, we need to say lower extremity. Because we have a thigh and a leg. Anterior portion of the leg is called the crural region. Posterior is called the sural region. You have your popliteal region behind your knee. And of course your ankle and foot. So we're going to start comparing the pelvic girdle, the pectoral girdle, and look at a lot of the differences. We compare the shoulder with the hip a lot. Where the pelvic girdle is going to attach is going to be the vertebral column. So when you hear you have a sacroiliac problem, it's because your pelvic is attaching to the vertebrae, specifically down to the sacrum, right? Sacroiliac. That's our attachment point posteriorly. Anteriorly, you have the pubic symphysis, which is in the front. So that's how they're connected, holding it and stabilizing it to the vertebral column. When you get down to the knee, we're going to see the knee, for as hard of a time it gets, is us walking around, running, making quick motions. Right? The knee really sits on a flat plateau. It can slide around a lot. So we have a lot of ligaments and especially large muscles that need to stabilize that knee, or we're going to have problems. I made a note there that the fibula does not enter the knee joint. This is where old chargers come to die nowadays. Sorry, I had a thought just then. The biggest scam on us in years and years is, Apple and Android makers, and back then it was Motorola, they all agreed to go to a common micro USB charger. Apple backed out. Everybody still has, every phone has a different charger nowadays. It's just a way to make money. What? And a lot of them are. Even Motorola and stuff. Either way. Well, the ones that are doing that now, though, are the any of y'all vape. Every vape has like their own proprietary charger, I guess. I look at people who rip this off. That's fine. Okay, so the knee, this is our knee joint. We'll discuss more later. What that's saying is the fibula is not part of the knee joint. It's below it, where it attaches, or where it articulates. Okay. And then the bones of the foot are different from the hand in that they're very large and they're adapted for bearing weight. We're not made to walk around on our hands, so the foot's a little different in how it's set up so that we can walk and ambulate around. Bear all that weight and still have stability. And then we'll look at all the flexor and extensor surfaces. So compare it once again to the shoulder. Look at the hip. The hip has to be weight bearing and strong, but it also has to provide locomotion. And so we got to look at what makes that up. The ligament and muscle balance. How do we make a hip that's very strong but can still have flexibility and motion, so you don't damage it? Same thing with the knee. A lot of bones, if you've never studied them, when we say hip, like I walk out here and I go, well, this is the hip. Well, that's really just a generic, it's an anatomy term, but it's pretty generic. Because each one of these is called the os, put this one out first. It's called the os coxae. And it's made up of 3 bones that fused, late teens, early 20s or so, I think. So they fuse together. So that's what the top is saying. Os coxae is what we call hips. But each hip is composed of ilium, ischium, and pubis. And they come together and fuse right at the acetabulum, where the hips, where the femur is going to articulate. Then we have our femur, we have patella, which is a sesamoid bone. We have our tibia and fibula in the lower leg, right down here. Tibia is always the larger bone, fibula is that stabilizing bone. And in the foot, we have similar sounding, but easier to remember, tarsals, metatarsals, and phalanges. So instead of saying carpals, metacarpals, now we have tarsals and metatarsals. So studying the hip first, we're going to work our way down these bones. Ilium, ischium, pubis, so they fuse. Sometimes you'll hear it referred to as the innominate bone. I'm not going to use the word innominate bone on the test. Hip, os coxae, more likely just the bones that make it up. So I boxed up a lot on this because we always look at landmarks. Some of these landmarks are important for like diagnosing stuff. Others are important because they're just attachment points for these large muscles. But you can use these for different things. Like this is This is anterior, and this is posterior. It's a little hard to tell when you're first doing it. We have our iliac crest up here. So when they're saying they're fusing, this is our ilium. This is our ischial tube, or ischium. And then you have your pubis out here. If you notice, they meet in this area here called the acetabulum, and that's where they kind of fuse. So up here on the ilium, we have some very important landmarks called the anterior superior iliac spine. Most commonly referred, we shorten it down, ASIS. Then you can have an AIIS, anterior inferior iliac spine. On the posterior side, you have two. That's posterior superior iliac spine, or PSIS. And then the posterior inferior iliac spine, PIIS. Here we have the greater sciatic notch. That's where our sciatic nerve is going to go through. And then we have the lesser sciatic notch. So I already described the acetabulum. At the bottom of the acetabulum, you have the acetabular notch. And one last thing over here, this, in between the greater sciatic notch and the lesser, you have this projection. That projection is called the ischial spine. So if we were really studying origin insertions, we would really get into what's attaching those. But there's other things that we can use them for that make them important to learn. If you look at like the dimples, if you're looking at somebody unclothed and you look above right where you see the coccyx or sacrum, often you can see the posterior superior iliac spines make a dimple there. Not in everybody, but that's about where you would find them. And well, I'll say it now just because I already referenced it, but like when you're doing, if anybody's ever done like a leg length discrepancy or somebody comes with an SI joint problem or hip problems, we often look for things. And one of the basic tests you can look for, if somebody has like a SI joint that's slightly rotated or something, it will pull. You got a picture. If my os cocci or my hip on this side comes up a little, that's going to throw your SI joint off in the back. So one of the things you can do is get up on people and find the posterior superior iliac spines and kind of reach around to feel the anterior superior iliac spines. And you can look and see, are those equal? Are they topped up? Are they rotated? Or you can lie them down. You got to do a few maneuvers to get your legs in the right position. And you can measure from the ASIS to the medial malleolus and see if one leg's shorter than the other. And then you got to ask the all-important question. Some people don't. If you find somebody, and leg length discrepancies that are going to hurt you, we're talking about like a quarter inch. Quarter of an inch throws the core center there all off, and you will start to have back pain, hip pain, knee pain. It just doesn't work well. The question you're going to ask, though, if you find somebody with a leg length discrepancy is, have you had this all your life? Did you know this? You may be measuring it, and they may already know. And they may maybe ask, do you ever have to wear lifts in your shoes? Maybe they did, maybe they didn't. Or maybe they've had it all their life and they never knew about it, never had a problem. Well, let's say they had it all their life, they didn't know, and you can't find anything else wrong with them, and you say, yeah, but you got a leg length discrepancy, so I got to get my next patient, I'm going to give you a little heel lift in your right shoe where that's at, you come back and see me. If they've had that all their life, guess what you just did? You made them worse. Because they've already, their body's adapted for that already. It's too late to be putting a heel lift. That's not exactly true, but you're going to mess up their mechanics because they're not used to having that. Okay. Pelvic, girdle, pelvis. The pelvis really refers to like down into these bones. But when we look at the pelvic girdle as a whole, you're going to have the os cocci that are out here. And then we have in the center, we have our sacrum and coccyx. And then they're going to join in the middle, like I said, this pubic symphysis. And if you picture this area down in here, kind of like a bowl, I messed it up, so let's look at this. if you're going down into this area, picture that dropping down and becoming a bowl. Like maybe a basin. Try and picture that. So they call it the pelvic basin. The ring around this is a landmark, and that is called the pelvic brim. Also, it's the pelvic brim, but it's also called the pelvic inlet. I'll explain that in a second. So I drew a black line on here that shows you the outline. It's only I drew one side. Outline of the pelvic brim. Anything above that is considered our false pelvis. Anything below that is considered our true pelvis. So if you come, it's easier to see in a real skeleton. This is the pelvic brim. So anything that is above that in this pelvic region is the false pelvis. Anything that's down in there is the true pelvis. The way I always remember that is, I don't do OB/GYN a lot. They stage like labor, and you're going to learn all that in OB/GYN. I don't even think about it anymore. But I often think, I guarantee it, if baby's head is not past the pelvic, or it's not past the pelvic rim, I always think, well, maybe you're in false labor when you came in. So it's not even started to push yet, right? So I always, to keep myself, which one's false, which one's true. The true pelvis, the baby's head is going between your osteotoxin. You're going to know you're in true labor. Okay? So anything that's below that would be true labor. The true pelvis. Don't tell OB/GYN I explained pelvis. They won't like that. Anybody ever work OB/GYN? Yeah. She knows it's not exactly how you grade that. Here's a side view of looking at the false pelvis there in fuchsia, or whatever it is, and then the true pelvis. So we know the pelvic cavity contains the bladder, the large intestine, internal organs, reproductive system, all inside of that pelvis. We're just looking at all the landmarks. But we are going to spend a lot of time looking at the differences between the male and female pelvis, and that way if you're ever on one of those crime shows and you're looking at the skeleton in the field, you can tell, oh, that's about a 22-year-old female. Bones in males are generally larger and heavier, not always. Good characteristically they are. Right? Most of the structural differences in the pelvis that we need to discuss and why we're even really discussing them is childbirth. Pregnancy, childbirth, just sets you up for going into OB classes for real. So I have several slides on these. When you look at the false pelvis, it's actually more shallow in the female. It's deeper in the male. And that's because, we'll get to that. The pelvic brim is actually more oval in females. Remember I said it's also called the inlet. When you look at the acetabulum, they're going to be smaller in face anteriorly, while in the male, slightly larger and they face more laterally. A little hard to see in pictures, but that's pretty true when you look at a pelvis. The obturator foramen, they both look the same to me here, but characteristically the females are more oval and males are more round. And then there's a key landmark. In female, this is your ischial tuberosity, it's your bony butt. If you ever rode a road bike for a long time, you know exactly where your ischial tuberosities are. And so the pubic arch will be greater than 90 in a female and less than 90 in a male. Iliac crest is going to be less curved in the female. The ilium is less vertical in the male, or in the female. That's why you picture female hips, and if you look at the female versus the male standing in front of you, you don't see those prominent hips coming out in males a lot. And that's because females, the males are still there as high as go up, the females are out a little more further apart, which opens up that pelvic brim. And so you can see the top of the iliac crest. The coccyx, when we look at that compared to the sacrum in males and females, the coccyx is going to be more movable in females. Oh wow, remember we're putting the baby's head through here. And curved anteriorly, and then the sacrum is shorter and wider. I know it's not, it's for testing purposes, it's studying what's at the bottom, not identifying these. Because to me, these pictures are very hard to kind of visualize that sometimes. So it's just learning the differences. And thinking about childbirth. Then we get to the true things we got to measure, the pelvic outlet. Well, we didn't talk about pelvic outlet. It's a very short area, but when you talk about the pelvic rim and then you go below that, this is the pelvic inlet. Baby's head's going to go in there and it's got to come out. That's the outlet. You don't have to get too deep on that. But the outlet's going to be wider in females to allow for that. The ischial tuberosities that we see here are shorter and further apart in females, and in males they're closer together and project a little more laterally, much larger. I keep coming back to it and saying, well, you want to put baby's head through here, or would you rather try it here? It's not going to be great. When you take reproduction with Rogerio, you'll see that not only is the bone structure set up for that, for a baby's head to go through there, and it's also why baby's head looks all deformed when it comes out, but you also have things in the body that get released, like relaxin, that will help all the ligaments, and your pelvis starts to kind of loosen up and allow that more wider area for that to go through. Head to go through. You can kind of picture there too in the picture that it's not great. They tried to represent the coccyx not being so pointed into that. The males you can see have a little more, but it's more than that. The coccyx is kind of out of the way, especially once you start going into childbirth. So interesting stuff, just studying what's written under them, don't study it for diagramming, okay, I'm not going to label this. Lower limb osteology, femur. See, we got out of the hip, we didn't study that here like the shoulder, right? But here we go on the femur. Femur and humerus, comparable thing, because we have a femoral head now. In the center of the femoral head, we have the foveal pit. That's where the ligament to the head of the femur goes, which is a branch of the obturator artery. They don't have to write that there, we're going to discuss it. Then you have a greater trochanter, and you have a lesser trochanter, just like we have greater and lesser tubercles up top. And here's a difference would make an easy question, that kind of thing, when you point out things. Anteriorly between the greater trochanter and lesser, they call this the intertrochanteric line, because it's pretty flat. They're represented on this thing. There's not great on that. When you look at the posterior side of the femur here, between the greater trochanter and the lesser trochanter, it's kind of smoother and it's raised, and so it's called the intertrochanteric crest. So it's a line on the anterior side and a crest on the posterior side. Right, then we're just going to drop, we have the shaft of the human, our femur, and then we have the lateral and medial epicondyles. So there's your lateral epicondyle, you have the medial epicondyle, and then we have the very large actual condyles, lateral condyle, medial condyle. That is the bones. Okay, hopefully y'all did last time, always, at least once, get on the skeleton and look. You have medial and lateral epicondyles, but these are the articulating points. These are the large condyles, and they sit on the tibia. I was saying earlier, the tibia is called the tibial plateau. It's flat, other than the fact we have meniscus in there. But if you think about the knee and how it can get damaged, it's sitting kind of on a flat surface. So those condyles are smooth. This is smooth. They start moving around too much, you can slip out of it. That's why I say you got to have that large musculature to hold that knee in place. All right. Before we leave the hip, I want to look at two abnormalities that can happen. You can have coxa vera or coxa valga. Changes. People have rickets, some type of process that weakens bone, whatever that might be, sex, age, development levels. You can see problems with the hip where they don't have a normal angle. Now, I do not need you to learn the percentage angle. But this angle of the femoral head to the shaft is generally about 126, they say 115 to 140. I'll exit for you. I don't want you to know the exact percent of the angle. I want you to know that if it's abnormal, what would they call it? If it's more, the angle's increased, what would they call it? If the angle's decreased, what would they call it? So if that angle is larger than normal, that's coxa valga. If it's smaller than normal, it's coxa vera. How do you remember those real quickly? If you can remember this, valga has an L in it for larger. Vera does not. That's the way I remember it. So coxa valga is a larger angle at the hip. Coxa vera is smaller. Got a cool pic for you. That's if you start looking at. If you look at these, it's an X-ray, of course. This hip looks just, you're not measuring it here. It looks pretty normal, right? How it should, like the picture up there looks. Look at this one. This is the femoral head. Does that angle look normal? No, it's much smaller than it probably should be, so that's coxa vera. Then you come over here at the, pay attention to the top picture first. Actually, both sides of this patient, this one looks semi-normal, but look at this one. Here's the head of the femur, and then the shaft straight down. So that's coxa valga. And down below, you can see they went in there and actually pinned this up so that it would have an angle to it. Whether that was from osteoporosis, weakened bones, a hip fall, I don't know. I don't know if that X-ray at the top was after trauma. Could be. It could have broke the femoral neck or something. If you're wondering what the glowing, everybody knows what this is. They got contrast, and it's just their bladder. Got contrast in there. Alright, the bones of the leg. I was starting to digress. I just didn't have anything to say on nothing. Y'all want me to keep going? We got a tibia, we got a fibula. When we look at the tibial plateau, you'll see it labeled over there, we're going to have our lateral condyle and then the medial condyle. So that's for the femoral condyles to sit on. Down below that knee joint, you have the fibula, and the fibula is, like I said, not part of the knee joint. If you follow the fibula down, it's going to end on the lateral malleolus, the bony outside of your ankle. Lateral side of your ankle is your lateral malleolus. If you start following the tibia down, let's see first that we have the tibial tuberosity. That's where your patellar tendon attaches to. Osgood-Schlatters disease area, that kind of thing. Then you'll go down the shaft of the tibia, and when you reach distal tibia, that will be your medial malleolus, or the bony side of your medial ankle. You look at a posterior view over here, I won't list every one of those again, I'm just going to, and of course, just like we saw in the forearm, there's the interosseous membrane, connective tissue, between fibrous connective tissue that helps to separate the compartments in this leg and provide some point for attachment of muscles and allow things to go through. So this is where when I reference things, I go, I think the lower extremity is easier, especially the bones and the muscles, but they did us some favors that they did not do us in the hand. And anybody who missed, I don't know if I asked, did I ask a question that confused you on the 3 T's in the wrist? I know I'm gonna do it. Is it trapezium, trapeze, you know? I don't remember if I did all that. I can't remember. think of it. In the foot, they got lazy like they do sometimes and helped us out. I don't know why they couldn't do it in the hand. And you have 7 bones, 7 tarsals, and you have a talus, calcaneus, navicular, cuboid, and then you have 3 bones that start with C, but they just said, you know what, we're going home. We're going to call it the lateral, the intermediate, and medial cuneiform. Name them all the same. Then you have 5 metatarsals, 14 phalanges. Same as that. So here's what they look like. Is you got to kind of orientate the picture. If you look at this picture, we're looking at it, this picture of the foot down there, we're looking at it this way. So in here is the top of the talus. The talus is the only bone that articulates with the tibia and the fibula. So this joint is called the talocrural joint, right? And the talus rocks up in there. The calcaneus is lower, the other foot bones are here. So if you're ever asked that, the only bone that articulates with the leg bones is the talus. So that's the view though that we're looking at. And when you look at that view, you'll see they have certain areas that are blue. And once again, that represents that it's articulating with bones. All the blue areas on this picture. So if we go in front of us, this is the talus down low. That's your bony heel. Or sorry, that's your calcaneus. Lost my mind for a second. Calcaneus, you have your talus here. Then if we come down into the midfoot here, you'll see we have the cuboid. We have the navicular. And then we have the 3 cuneiforms where we have the lateral, the intermediate, and medial. And of course our metatarsals, 1, 2, 3, 4, 5, and then we have our phalanges. So set up after that, we're similar to the hand. So if we flip this over now and we look at it from this view, and I'm looking at the foot this way now, now we can prominently, we can still see all the bones. We can see the calcaneus better. You can see your talus over here, it's down below. And then you see the navicular. Navicular sits about where you would picture the scaphoid. Right? You have your cuboid, and then your cuneiforms here. The only other ones I want to note on here is when you're orientating, if you're looking at, am I looking at the bottom of the foot or the top of the foot, you look for these sesamoid bones. You have 2 sesamoid bones underneath your first metatarsal, your great toe area that you can find there. Or even on the skeleton here, these are sesamoid bones. That tells you you're looking at the bottom of the foot. It's the easiest way to, if not, you might get your bones and tarsals wrong, right? Alright. Those are the bones of the foot. We'll discuss them more. There's no unique blood supply to the navicular. I forgot to check. There's normally I throw you out of class if you missed question 50 on the last test. Just joking. But if you did, and I had gone and looked and it was you, I'd have to scream at you and go, I don't care if the person woke up this morning and had scaphoid or tendinous anatomical snuff box. That's a scaphoid fracture. I don't care what it reads. I didn't know the stats. Just I'm grading you if you did this. Still love you. Still love you. And now you know you won't ever do it again. You know, okay. Alright, arches of the foot. And when you get into podiatry type stuff, they really look at this. It used to be nobody talked about this, but now everybody, you know, they don't go buy their great running shoes at Walmart. They go to these foot stores, they measure them, they're looking at all these different arches. You know, they've come a long way. She'll talk about these in podiatry because there are actually 3 arches. We talk about, well, the arch in my foot fella. I have a low arch, I have a high arch. There's actually, these are imaginary lines, of course. There's actually 3 arches that they discuss with the foot. And they're just held in place by ligaments, tendons, and bones, or tendons and muscles. So you have the longitudinal arch that has 2 parts. you're going to have the lateral part of the longitudinal arch and then the medial part of the longitudinal arch. These arches are going to help us as we walk around to distribute. Oh my goodness, did I already? Let's take. Let me finish the arches and then we'll take a break. I'm just having too much fun. Y'all are just so quiet. I mean, arches distribute weight. We already know that. You got plantar fasciitis and you jump up in the morning, you already know your arches distribute the weight. Okay? They provide leverage while walking. They yield to weight. They spring back. What that's talking about, if you don't know Gay valves, when you start walking, right, you'll learn that you do heel strike first, then you have swing through, and then you push off. And so as you're walking, that arches not only decelerate your motion, but they have a little spring in it, with a spring ligament, no doubt, that when you roll over, your arches help propel your next step. You know, unless you're one of those people that walk around on their heels. And if a kid's walking around on their heels, that is a incomplete development of the corticospinal tracts, but you don't need that. And they'll grow out of it. They'll grow out of it. I think I say that somewhere in here. I say that because I know a girl, we're going to take a break. I'm not even going to finish these, but I know a girl who's a great basketball player playing in college right now, and I helped coach their basketball team for years and years when she was younger. But I met her at 5 years old or something with my kids. Yes, I have to admit, my kids that did play soccer when they were young. Sorry. Anyway. But she would outrun everybody, but she ran on her heels the whole time. And I always wanted to tell her mom back then, I told her later, so I wanted to go, do y'all know that stuff, Mom? But she progressed out of it, was a great athlete then, but she's really good now. I don't know where she plays in college. Y'all go take a break. Her playing in college had nothing to do with my coaching in basketball. I was a motivator. I knew how to scream, back door!
How are they doing? Why do you consider it? Other than having autism, that's like, yeah. Why is there an autistic kid who can't develop properly? Why is there natural instinct to go find their child? Of course, you can't learn something else, right? You should learn basics. I mean, you grow up on the toes. Think about it. You're just weighing all your weight. You're not clumpering around. It feels
You're exaggerating flat-footed. I'm not saying you're flat-footed. I'm saying natural age is you do feel straight.
it's true. Think about it. Kids naturally do always they grow out of it. But they're not like, what? You always just see kids like,
I agree. Like if you're going to do any sort of pickup motion, then you're striking more front middle, like front side foot. But like even when we're having a game conversation, how big is that? Evolutionarily, we've gotten it where we feel.
We evolved from apes. Why are we still
Yeah. Now, Audie, flat foot is one leg.
Yeah, it's like my aqua water usage is like $10 per bottle.
Oh, okay. So that's it.
I was thinking about that too because I feel like the argument falls flat when neurological development, like if it's not happening properly, like I think technology show me some data. See like so like yeah like pathological cell walkers. Why do you say weird? Weird things. Oh, thanks. Yeah. Gift from the whole house. You know how like people so it's always so funny because like they're always like, yeah, they don't have kids. Well, thank you. Yeah, we had one. I told you we had one that was like a water activated. So bathtub, turn on like the reset, and then say yeah, it's saying baby shark. Oh yeah.
Movies get ruined right now because I watch people like New York City or Lucy Potato. First medical thing I ever did wasn't even in my just when I graduated high school. I went on a ride along with thank God. We got called to a stroke, and he's like, I'm like, ooh, can I do anything? He's like, well, I'm not doing CPR. You're doing CPR. So we get there, and this guy's like out. The EMT already showed up and tried to get like CPR going. It didn't work. Every time we were like, he just threw me on there. They're doing it while we're trying to get this guy back alive. And I'm just in civilian clothes, doing CPR, and he just got freaking coming up out of his mouth. Doing CPR. This is the day after Thanksgiving. extra full, extra. We've been casting. And anyways, they didn't know what happened. So said that 30 people did their turkey trial yesterday. Said that he felt like having a race. Get to the hospital and so what we found out later was it wasn't that he had dissected while I was doing some blood was then going to the stomach, and I was pushing it down the stomach to push down all those contents and that was and he was dead before we got there. Then my brother's like, no, we knew it. He was dead. All the family was watching, so we are. Yeah, that was my first medical that I did. And I was like, I can do this. I didn't throw up. I didn't freak out. I just saw a dude die. I guess I can make that exciting.
I'm totally okay. I'm no problem. Also, my
we heal him and probably. You had to go to school for it. Don't you love the like Stolen Valor videos when they got like Ranger and like Scuba Suit and like all these I actually never walk around. Okay. Stay still. Ready?
So like
We were talking at the break about why I was out there over yesterday. And I doubt volume was still in my system, they only gave me one. I wouldn't have taken a script for it anyway, I don't need any type of that class. But for some reason, a 10 milligram Flexeril, like if I took that this morning before I got here, I wouldn't be teaching. It wipes me out. But if you give me a bottle of Robaxin, I can eat those like Flintstone vitamins. That does nothing. I've never prescribed that to anybody unless it was renewing my life. I guess some people respond to them. They've given me that before and I'm like, nothing. Just give me the little bitty Flexeril, I'll be good. I'll be off. You know, I don't know why I tell you a lot of stuff. It makes it fun. And I'll have somebody to talk about in your later years. Okay. What we're going to do here is go through the arches, and we're going to we're going to learn by definition what bones are considered to make up that arch and what helps support them. So that's your importance here. So we have the longitudinal arch that has two parts. The medial part, you would say, originates back here at the calcaneus. It rises to the talus and then descends through the navicular, the three cuneiforms, and the heads of the first three metatarsals. That would be your great toe, second, third. That's the way you need to learn it for me. The lateral part of the longitudinal arch also originates out the calcaneus. It rises to the cuboid and descends to the heads of the two lateral metatarsals, the fourth and fifth digits there. So those are two different arch portions. When you look at the arch across the top of the foot, you have the transverse arch. And it's formed by the cuboid, originates here, and then the bases, the cuboid, the three cuneiforms, and the bases of the fifth metatarsal. All of them, not the fifth, of the five. So it goes across top, like a little bit below where you tie your shoe. Interesting thing in the foot is we were talking about gait evals today. When you walk, you don't have to learn percentages. About 40% of the weight when you walk is carried on the balls of your feet, at the front of your foot. If you look at a actual foot, we're talking 60% of your weight's back here on the calcaneus when you walk, about 40% is up here. That's called the balls of your feet, right? The metatarsal head. And so we walk and pivot on that. But when you take like a high-heeled shoe and alter your mechanics up, we can shift in a high-heeled shoe to where about 80% of the weight is on the balls of our feet. That's how you get ugly feet. If you wear heels too much. Right? If you're up on your toes, you're putting so much weight on that. If you think of like a ballet dancer, like my daughters did point, and well, I never saw the point of point, but they're beautiful doing it. That's all I know. Okay, I don't like going to the shows. So. Oh, goodness, do some more hip hop or something. I don't need no ballet. Anybody know what I'm talking about? No. Well, they're up on their feet, and so they get metatarsal stretch fractures and things more than other people. Not only that, your ankles, we'll talk about your ankles are very unstable once you're up like that. And so you've changed the mechanics. That leads to other things like bunions, because the normally heels are pointed in the front, that kind of thing. So now we're going to back up. We'll get back down to the, we looked at all the bones. Now we're going to start looking at the tissues. And so we start back up in the thigh. You have the fascia of the thigh that's going to connect all of that skin to bone, muscle to bone. It forms compartments just like we saw in the upper extremity. In the lower extremities, we talk a lot more about how it forms a very tight sleeve over those muscles. And in the lower extremities where we start worrying about things like compartment syndrome. So that sleeve of support in the thigh is going to include all of that fascia. You're going to have a thickening of the fascia on the lateral side of each leg called the iliotibial band. Then you have the crural fascia down in the leg. and then you have a retinaculum at the ankle. So this is all continuous. So this is just the thigh portion of it. Is all of that yellow you see is fascia, and then you have, it'll tie together eventually into iliotibial band out here. We're going to talk a lot more about that, and this is this hiatus here, a defect. Okay, so the fascia lata is considered the deep fascia of the thigh, and when we look at the inguinal ligament, that's where it attaches, so up high. So it's going to start up in this region where we have our inguinal ligament, our groin. And then at the top of that, we have the saphenous hiatus. They call it the saphenous defect. I don't know why they call it a defect. It's just an opening. It's a hiatus. And we will learn here in a second, this is the greater saphenous vein, and it empties into the femoral vein, and it's superficial to the fascia as it gets to that point, but then it goes into the femoral vein by going through the saphenous hiatus or defect there. More on that in a second. And then you have septal divisions that make up the compartments of that fascia. Where all of that fascia on the lateral side ties into the iliotibial band, also inserting into the iliotibial band is gluteus maximus and tensor fascia lata, the muscle that tightens the iliotibial band up there. Don't worry, we're going to get back to all of that. The crural fascia is talking about the leg. Right, so crural fascia, we have anterior borders on the medial and anterior borders of the tibia, and it's connected to the periosteum. That's why if we start to pull that fascia or those muscle groups, you can start to develop things like shin splints, right? You pull that fascia and the periosteum off a little bit there. And then that's also going to divide us into the three compartments of the leg. And then at the bottom, when we get down to the ankle, we're going to see that the fascia makes retinaculum. We have extensor retinaculums, flexor retinaculums. We don't study them so much in here as in carpal tunnel type stuff, but that could exist in the form of like tarsal tunnel. But the point of the retinaculum is just to hold all those tendons down. Looking at the arteries and veins that are going to be important in this area. You have the abdominal aorta. So we stopped last block, or sorry, the block before last really. We stopped at the abdominal aorta right before it split. But when it gets to about the level of the fourth lumbar vertebrae, it's going to divide into the internal iliac and external iliac. The internal iliac is an artery that supplies the pelvis, the pelvic viscera, the perineum areas, the gluteal muscles. Right? It's also going to provide an obturator artery, which is going to be important because we talked about blood supply to the head of the femur. So that's going to go internally. Then you have the external iliac. The external iliac, when it crosses the inguinal ligament heading down, it will become the femoral artery. The femoral artery behind the knee will become the popliteal artery. I don't want to get too ahead with my slides, but you're gonna have a femoral artery that's anterior, but then it changes to the popliteal artery when it's behind the knee. So there's an area called the adductor hiatus where it can go through and get behind the knee. And then when we get down to the foot, the only arterial spots we're going to worry about is the popliteal. Actually, in the leg, divides into anterior and posterior tibial arteries. And then in the foot, it becomes dorsal pedis on the dorsal surface, and on the plantar surface, you have the medial and lateral plantar arteries. So go to our schematic. I just put them both on the same slide here. We can see that here's our abdominal aorta, and then we split into the left and right common iliac. Then we'll have an internal iliac that goes to the pelvic region, and then our external iliac, once it crosses the inguinal ligament, will become the femoral artery, which will go down the thigh, and there'll be a little opening here. Adductor-hiatus, and it'll go behind. We have to switch over here, go behind the knee, and become the popliteal artery. Once you pass the knee, you'll divide again into the posterior and anterior tibial arteries. And so that the posterior tibial artery will continue to run down the back of the foot, the leg, and the anterior tibial artery will flow out over here, anterior. So I like to circle these for you because you're always looking. So here's your iliacs, common. You have the external iliac, the internal. Remember, internal just goes to the pelvic region and gluteals. Then you have our femoral, our popliteal, anterior, posterior tibial arteries. It goes into dorsal pedis. And then we have the medial and lateral plantar arteries. The only ones you got to pick up on. The other ones I didn't circle are down in the foot mainly. Realize once again, you have arterial supply coming in the foot, it makes an arch and connects, provides digital branches. We just don't even get into the minute ones down there. And we got blood down there, we gotta get blood away. So you have the lower limb, superficial and deep veins. The superficial ones are in subcutaneous level. They're not within the compartments. Right? The larger, deeper veins are going to be within those compartments themselves. They're deep fascia. Both of these, superficial and deep, have valves. Now we didn't talk a lot about valves in the upper extremity. They exist there. They're necessary. But if we think about it more in the lower extremity, as you're standing here, blood's going against gravity to get back. And so you use several things to help it get back. And one of those is valves that allow blood to be pushed back towards the heart without just going right back down. Unless you have insufficient valves to get varicose veins, right? So it's pushing it up through it, and these valves hold it. But as the muscles contract around the deep veins, that also pushes it back towards the heart. You may have gone over that in cardio. So there's your deep veins. They're named for whatever arterial supply is deep in that compartment. You'll have a vein next to that. And they will have a lot more valves. The superficial ones are called the main ones. There's a lot of superficial veins. We're only going to look at two. There's the great saphenous and the small saphenous, sometimes called the lesser saphenous. The great saphenous. So the great saphenous starts at the dorsal vein of the great toe. I'm not worried about dorsal venous arch. It just starts at the dorsal vein. Just so you know, it's on top of the foot. And then it goes anterior to the medial malleolus, along with the saphenous nerve there, and then passes posteriorly to the medial epicondyle femur. I'm going to draw this out for you. And it connects all the time with the small saphenous. They connect, so we're trying to shun as much blood as we can back up to the heart. The great saphenous goes all the way up and empties into the femoral vein. The small saphenous is on the small toe side, still dorsally, vein is, and then it ascends posterior to the lateral malleolus, accompanied by the sural nerve, and then empties into the popliteal vein. So let's kind of just look at this. It's easier to see. Here's your dorsal vein. We're saying on the medial side, you're going to have the great saphenous vein that goes in front of the medial malleolus, goes up the leg, it kind of tucks itself. Think about protection from damage. It goes behind medial malleolus a little bit, and then wraps around and comes back up the thigh, and it empties into the femoral vein at the saphenous hiatus. That area is also the femoral triangle. When you look at the opening there, this we'll discuss. We're going to learn the borders. We're going to learn all about the femoral triangle. This is called the femoral triangle, and you don't lose boats or anything in there, but it is a place where I know I'm sounding very monotonous at the moment, so I had to add something there. You have the opening, the defect. Alright, the small or lesser saphenous goes behind the lateral malleolus, the distal portion of your fibula there, and it will go up and empty into the popliteal vein. Connecting these, we have perforating veins, a lot of them. I said they connect. The perforating veins also have valves, right? So they're only allowing blood to flow one way. So because of all the perforating veins, our greater and lesser saphenous veins remain pretty much the constant level. So we're shunting as much blood as we can into the deeper veins, because there we have the musculovenous pump, the muscle tightening. Like you ever been on a long flight and you can't get out? You know, especially the older you get, people should be doing things like ankle pumps. Keep the blood moving back towards the heart so they don't develop clots. You're sitting with the knees flexed, get up and walk around. Like you can, especially as you get older, develop clots because your veins are not as, the valves don't work as well. Anyway, so the key point there, your deep veins become larger as they get closer to the heart, or closer to leaving the lower extremity. Our deep veins accompany all those arteries, the limb, they're generally paired, right, rather than a single structure, that venous comitates we talked about. You have the musculovenous pump. The musculovenous pump, like I said, contracts the muscle around that and will help to push that blood back. You also have the arteriovenous pump. Did y'all discuss that in cardio? Is the countercurrent heat exchange, that's still going on. You know, venous blood being warmed by arterial blood. I'll just mention in general that if you have clots that develop in a superficial vein, like around the knee and varicose veins, you can get a clot. That's a lot less dangerous than having like a clot in your deep veins of your leg or your thigh. Deep vein clot, DVT, right? Red hot, warm, tender, pneumonia sign, that kind of thing. If you have a clot that size, that can go up and become like a pulmonary embolism or even go higher. Small superficial veins, you can get a clot in there and not have as much problem. It's probably not going to be large enough to take you out. Okay, so here's your schematic. I'll do the schematic here first, and we'll work our way back. So you have the great and small saphenous veins. The small saphenous vein is going to empty into the popliteal vein, and the great saphenous will empty into the femoral vein. On the venous side, deep veins we have to look at, we have medial and lateral plantar veins. You have the right posterior, right anterior tibial vein. They also empty into the popliteal. That will go up to the femoral, into your right external iliac, common iliac, and then to your inferior vena cava. That's our important ones. I don't like to use schematics on the test, so as you make all these diagrams, is it still working? I think I'm dead. Maybe I'm losing it. Y'all can't hear me in the background. Or is it just that I'm droning myself out being monotone? Yeah. Okay. Fair enough. I'm not always monotone, but when I do it well. Okay. Inferior vena cava, right? Common iliac, internal and external iliacs up here. If you follow that down, you'll find your femoral vein. You have to come around to the other side, you have your popliteal vein back here, anterior and posterior tibial veins. I know I'm not drawing it exact. Making your way down to the medial and lateral plantar veins. I already showed you on other pictures are greater and lesser where they go. They're superficial. Okay, so if you have incompetent veins, you wind up developing varicose veins. When veins become tortuous, dilated, they start to show up. These are a little different. Spider veins are varicose too, but a lot of people as they get older develop spider veins in their lower extremity, and that's not a problem at all. It's a cosmetic looking thing. They go in and get them lasered because they don't like them. Varicose veins looks more like they are in the next picture. The valves that are generally causing the problem, and you see all these tortuous veins, is your saphenous veins, your superficial two saphenous veins. They're more susceptible. Remember, they have a less dense arrangement of valves than the deep ones. And so this is a good example of varicose veins. The spider veins are really small. You see a bunch of them. And then a few people in here old enough that probably have a few spider veins down by the ankle or something. But you see people like in the military with varicose veins. A buddy of mine in Hawaii, he always had to wear that band around there. He had really bad varicose veins behind his, or below his knee. I won't say how much of a hard time I used to give him about being old. He was the same age as me. But there's some, you can see some spider veins down here, see? Perfectly normal. Alright, muscles. A little more interesting. We're getting the muscles of the lower extremity. We have our extrinsic muscles, meaning they're not part of the lower extremity itself. And you have your intrinsic muscles that are in the free limb or the leg itself. So psoas major, actually minor also, we're going to see go together. Intrinsic muscles are iliac or iliacus. It's going to be part of our psoas group. The gluteal region, the thigh regions, our leg compartments, we have three. The dorsum of the foot, sole of the foot. We're not going to really get into the muscles of the sole of the foot like we did the hands. So here is the first group. We said psoas major, but minor also. Psoas major and minor are two distinct muscles, but they're often grouped together. You'll have psoas major, psoas minor, and then you have iliacus. Collectively, those are iliopsoas. Hip flexors, that kind of thing. They're called that because psoas major and minor originate off of the transverse processes of the lumbar vertebrae. So that means that they could probably help with hip flexion. Or think of it more as like holding yourself on a pull-up bar and bringing your legs up. They can help with that. They're going to insert into the lesser trochanter of the femur. So they can do flexion of the hip and flexion of the vertebral column. Remember, this always holds true, always for the most part, is that if they're close to the vertebrae, they're innervated by spinal nerves, and that's exactly what happens there. So the psoas muscles, major and minor, are innervated by lumbar spinal nerves. But we're talking about the group as a whole. There's another muscle here that originates off the iliac fossa and sacrum, and that's called iliacus. And iliacus also inserts at the lesser trochanter of the femur, but it's only going to be able to do hip flexion. And it also has a different nerve supply, it's femoral nerve. Well, you're about to see how I compartmentalize the lower extremity, and we're going to look at the muscles that are in there. And so while psoas major and minor are really extrinsic muscles of the leg, iliacus is really an intrinsic muscle. So most of the time we put iliacus in its muscle group, we put it in the anterior compartment of the thigh. And part of the reason for that also is because the muscles of your anterior thigh are innervated by the femoral nerve, and so is iliacus. So here's just an attempt to show you, and I'm not going to separate the differences. This is psoas minor, and you have psoas major that's much larger than that one, and they're just going down to the lesser trochanter there along with iliacus. And then we have worked our way to the hip joint. This is where we really compare it to the shoulder, because the hip joint is a ball and socket joint. It's a synovial joint, has a lot of movement, and it is very unlike the shoulder. When we look at this joint, like I've said many times before, this is going to be very deep in its articulation compared to the shoulder. And we can move very easily out of socket. So the hip's much stronger. We also have a lot more stabilizing features. Rotator cuff's great, but it's nothing like the ligaments that protect the hip. We got to look at the bony structure. The femoral head is a ball, and it sits deeper into the acetabulum. So it has more of a bony articulation possibility than a socket. Then you have those strong ligaments and muscles. Along with that, we have a very strong calf, or the labrum, the lip of it, that comes out and holds on to this bone. If you look at motions of the hip, you can have flexion, right? Bring it out like you're kicking the ball. If you have extension, you're bringing it back. We can do abduction and adduction, bring it out, bring it back in, and you can do circumduction. So if you have circumduction of the shoulder, you can do the same thing with your lower extremity. And I'm going to describe these, and I'll show you on a good picture next. Is the acetabular fossa is the center of your hip, your os coxae, but in the middle of it, you have a non-articular part that has a synovial fat pad. I'm going to read them, then we'll go to the slide. There's a lunate surface, which is the true articular surface that where the femoral head is going to articulate in that acetabulum. The bottom of the acetabulum, you have the acetabular notch. And that has a ligament called the transverse ligament of the acetabulum that closes off that notch. And what we see is an artery, a ligament and an artery that's going to go through that to get to the head of the femur. Then you have the acetabular labrum, which increases the depth of the acetabulum. It's a very strong fibrocartilaginous kind of lip that's going to hold on to the equator region of the femoral head. Okay, so if we look at the femoral head, I still feel like this thing's like cutting out. If you look at the femoral head, it's very smooth, not so much of a difference on the skeleton like this, but it has a line that's here. This is called the equator. So when you look at the hip, we're going to see that there's a fibrous labrum that comes off of this and comes out to the equator and kind of holds it in, like you rotator cuff. Well, there's an equator of the hip and it holds on to that. So it's very strong. You'll see it in the pictures I'm going to show you where they cut it away. And so here's the hip joint's been cut open. Now, that box and everything on it. That's awesome. My favorite kind of picture. Actually, because it's a great picture. A great picture when you can box what's important and not a bunch of extra things laying around. Let's go through what we just talked about. This is the synovial fat pad. That's inside of the true acetabulum there at the bottom. The lunate surface is here. Right, so the lunate surface is going to be a type of hyaline cartilage. If you remember back to bone formation, the ends of long bones is hyaline cartilage. So this smooth portion of your femoral head is also like a hyaline cartilage that covers it. It's going to articulate with that lunate surface. But you have the acetabular labrum that has been cut away from this equator here. Okay? Look at the next slide. It has a picture too. I'm sure. And so they've taken this, cut it, and kind of opened this up. And actually, we have a specimen over in the lab, and you can see exactly that. This is the transverse acetabular ligament. It closes the acetabular notch. It allows the ligament to the head of the femur to come behind that. If you notice that little red dot inside of there, that is the artery to the head of the femur. It's a branch of the obturator artery. Leave anything off of there, the neck of the femur, lesser trochanter capsule. So this is kind of a cool picture of an actual specimen, where you can see those smooth articular surfaces, a lunate surface. You can see that there's kind of that fat pad down in there. You can see how this portion has been cut. This is the labrum. And so if you picture that coming back towards you, putting that hip back in the socket, this is the ligament to the head of the femur. It has a branch of the obturator artery in it, and it supplies the blood supply to this area here, all of this area. This area of the femur does not get blood supply from anywhere else. Key point there. If you tear that ligament to the head of the femur, that part of the femur will necrose and die. And I'm not going to talk about it and bring the video up unless I feel like it's fun, but I used to show a video of Bo Jackson tearing his, just so that I could introduce everybody to Bo again and help you to realize that Bo Jackson is the greatest athlete of all times. I'm not sure a Jim Thorpe era guy or something like that, but you know, he played 2 sports, Hall of Fame level until he messed his hip up. And then he was still better than any of us in this room at baseball. He's the one who started the whole bat breaking thing. I love to see people try his bat break and they fail. He would break the bat over the top of his helmet when he like struck out or something. But he would just snap. It wasn't that or his leg. I love when you see somebody try to break the bat on their leg and it just bounces off. Yeah. Bo Jackson, maybe I'll show the video tomorrow. But Bo Jackson was the greatest. And he was running though. The guy was able to tackle him from behind. He was running down the field and was able to clamp down on one of his legs. And they say in the 30 for 30, the doctor talking about it, saying that he probably did the damage when he put it back in because he was so powerful, he tried to yank his leg out. And you hear him describe, you know, he went down, and then he rolled over and popped it back in. The hip doesn't come out. That's the whole reason I would show the video is, if you're going to take your hip out of socket, it takes a lot of force. But he was able to do that and pop it back in and sheared this artery and wound up with a hip replacement. Still probably outrun all of us. Okay, now he does bows and arrows. It fits. Okay. He also made $1 billion for Nike. When in the 80s, if you didn't know Bo, yeah, I'll stop. We needed something besides anatomy for a second. The acetabular cartilage, like I said, is very smooth, and the femur has that same cartilage, and so it's going to allow it to rotate around in there. This is actually a better view of that ligament. Ligament to the head of the femur. The reason I keep calling it that is because I don't like to, you got the long name. Ligamentum capitis femoris. Ligament to the head of the femur. Very weak. When we look at the capsule and how strong it is and the stability of the hip, this ligament will be listed in those. But it doesn't really provide stability. You shear that, you don't have to dislocate your hip to tear that. That's the scary part. You can grind that hip around, do damage to that ligament, and still tear that. And have some pain for a few days, and by the time you get in there, it's too late. They're going to go in there and clean that out, maybe hip replacement for you there. It's going to die. The head of it, head of the femur. All right, let's see. Let's cover the articular capsule. That'll probably get us through the end of our time. When you look at the articular capsule, it's very, very strong. But it's best to allow a lot of movement. So the large ligaments that are part of this are the iliofemoral, which prevents hyperextension. It's one of the strongest ligaments you'll find in the body. It's Y-shaped, so it's often called the Y ligament. And another name that's been given is the ligament-induced Bigelow. Yeah. I'm going to throw that in there until people stop laughing, and then I'll realize they don't know who big blow is anymore. So when we would take patients, this ligament is so strong, somebody doesn't have lower extremity function, paraplegic, we could actually transfer them, stand them for temporarily, and they can sag. Y ligaments are in the front, and it prevents hyperextension. And we could sag, they can sag, come in and hold them up, kind of like a sack of potatoes. That ligament is so strong that it can help you hold them up while you transfer them. And they're kind of sitting like that, standing like that. Some you'll get into more when you get into physical therapy type stuff. You also have the pubofemoral ligament, which prevents over-abduction. And then you have the ischiofemoral ligament that prevents hyperextension also, and the ligament to the head of the femur. So all of these help stabilize the hip joint. Let's look at them in a picture though. Come on here to this side. This is our iliofemoral ligament, which is called the Y ligament. Back here, we're still anteriorly here. You can see this is the pubofemoral ligament. So if we go back and say, well, pubofemoral prevents over-abduction, iliofemoral prevents hyperextension. So it's not going to allow hyperextension, you can't bring it back too far this way. And then the pubofemoral is going to keep you from over-abducting. We have to kind of take it to the back side to see our ischiofemoral, which also prevents hyperextension, over-hyperextension. And you can see a little bit of that iliofemoral up here. Two other important ligaments though that we have to discuss in the hip are looking at what, if you're wondering on these ligaments, what I want you to know, I want you to know what they are, of course, but it's more important, which one prevents over-abduction, which one prevents hyperextension, okay? I want you to learn that. Just wanted to be clear because I didn't really say it that way. And I want you to know what these ligaments do. That's what made me think of it. Is we have what's called the sacrospinous and sacrotuberous ligament. You may not be able to visually picture what these do until you see an actual pelvic region, skeleton over there, or specimen at the angles that they look, because pictures don't show you exactly. So it's one of those things where you have to learn definitions. Right? So the sacrospinous ligament closes the greater sciatic notch. So this is the sacrospinous ligament. Well, it's going from the sacrum, and that's the whole region I pointed out. Remember the ischial spine? Whoa. Sacrum to ischial spine. That's why I pointed that out. It sits between the greater and lesser sciatic notch. But by definition, the sacrospinous ligament creates the greater sciatic foramen. The sacrotuberous ligament goes from the sacrum down to the ischial tuberosity, where it makes an insertion. So the lesser sciatic notch is converted to the lesser sciatic foramen by the sacrospinous and the sacrotuberous. The reason I brought up, and that's what I want you to learn in the bottom part definition, the reason I brought it up is because when you look at this picture, it kind of looks like that, well, doesn't the sacrospinous and tuberous both make the greater sciatic foramen? No. And if you look at it in 3D real life, you'll see that that's the case. Just the picture doesn't do it justice. And over here I noted that transverse sciatic ligament again. All right. So last slide for the day. The hip joint is most stable when it's fully extended and bearing weight. So when you're standing. When you think about how you make the hip joint unstable, if you're going to call it unstable at all, is to sit like you're driving. It'll sit like you're sitting now. Or you picture driving a car though. And so if you have the hips flexed to 90, the knees flexed to 90, that is the weakest point for your hip, where you can do damage to it. That's why it's kind of rare. How much force did it take? Well, let me say this first. if you're gonna knock your hip out of socket, most people, you're gonna fracture your femur at the same time. Because how are we gonna do it? We're gonna do it by driving, and the dash is gonna hit our knees and push them backwards. Take that hip out of socket, but a lot of times before it even comes out of socket, it fractures the femur. That's how much force it takes. And then you picture like somebody just, Bo Jackson, running down the field. And I just said it, your hips in its strongest position when you're fully extended, hips fully extended. And he was tackled going down, leg fully extended. You know, they tried to pull out of the tackle, and that took it out. That takes a lot of force, is what I'm saying. If you've ever been in ortho and seen them do a hip surgery, you understand how hard it is to get the hip out of socket. They got to take that out of the socket, saw some things off. Hip surgeries, you're going to enjoy them. They got to get out the hammers. Start driving. I love when they drive the rod down through the femur. And then, you know, they put the rod in, and they put a, we got some in the lab, you know, like the specimens this round. They kind of screw the ball onto it, small head. When they hammer that thing down into the femur, a little rod, it gives you chills up your spine to think about it. What really gets me is they hammer it down there, and then they're like, and they take it back out. And I just picture being awake. Well, I mean, how could you'd pass out? That's gotta hurt like hell. Oh my goodness. And that reminds me, if you need a very good laugh, and I was gonna play it today, but because all I thought about in the ER is there was a comedian, it's worth looking up today, because y'all all look like you need a good laugh, just like me. There is a comedian named Brian Regan, kind of like Reagan, but Regan, R-E-J-N. And look, Google or wherever you use, Brian Regan emergency room. He goes through the patient's perception of the pain scale. He goes through, I won't ruin it for you, but it'll be one of the funniest medical things you ever heard from a patient perspective, like asking him, you know, on a scale of, you know, on a pain scale, where are you at? You know, and he's going like 2 thumbs up, you know. They ask him to describe his pain, and he's like, you know, what are we playing? This pyramid game? Horrific. Excruciating. No. He even goes so far in the beginning, he's talking about, I think that, I mean, it's a complete oversight that you feel like you're dying, your friend takes you to the hospital, and they don't have valet parking. So you like kick them out the door, and you're like, all right, you go in, I'm gonna go find parking. Tell him you're shot. No, I'm not funny like him. But it's worth it as a medical vitalistic. It gives you a perspective. You really want to explain the patient's pain scale and stuff better than those little charts. On 1 to 10, what's your pain level? They don't even know what those mean. That's a very funny video because it gets into femur fractures versus pregnancy. And my favorite part, and I'll leave you with this, is the guy that was seeing me, the nurse yesterday, he said, sorry, the guy in the next room is moaning, and he didn't do what I told him to do. And I said, I'll just have to out-moan it. And he had never seen that video. The video is worth watching just for that. He says, because in the ER, you know, he's like, it's like a crazy sanitary, we call it crazy place. He says, there's all these people moaning. He says, so I'm there, there's just some sheets between us, and the next guy's over there going, oh, and he's thinking, if I'm dying over here too, I'm never going to get help. I got to out-moan him. Oh. Go watch it. You'll enjoy it. Y'all have a good day. I'll see you in the morning.